You can even today do a clinical evaluation remotely from wherever you are. After all of us, even the non-specialists, we know that COVID-19 essentially involves having fever, having a sore throat, cough, a running nose, and so on. As you can see from this slide, today we can monitor somebody's temperature remotely. Even the relative of a so-called afflicted patient, all that he needs to do is to focus a bright torch, and I, sitting hundreds or thousands of miles away, can look into the interior of the throat, into the interior of the ear, and so on. Already, robots have been deployed in other countries which actually take swabs. A robot takes swabs under the supervision of a human. In Madras alone, in Stanley Medical College, and in other institutions in Tamil Nadu, robots have already been deployed in the area of COVID-19. Bluetooth-enabled stethoscope. Today, it is very, very simple to transmit an audio file. I would not like to diagnose pneumonia when both the lungs have the chest X-ray is obvious. I would like to pick up Rals and Ronca. And believe me, I can do this even if I'm thousands of miles away. Pulse oximeter, oxygenation. We have heard of the Prime Minister of UK being hospitalized in an ICU purely because to monitor his oxygen saturation and ensure that he gets adequate oxygenation. A 12-lead ECG, even a pocket ultrasound. This may not be relevant under the COVID-19, but it is certainly relevant today when a person with an acute abdomen or a lump in the abdomen may not be able to go to a hospital. So these are all peripheral medical devices which have been used for several decades, even in India. Why is telehealth so important in coronavirus? Now let's spend a little more detail. Triage. It is very, very important that the government has been repeatedly telling, the media has been shouting this ad nauseum, stay at home, stay at home, stay at home. How can one get medical care when you stay at home? Yes, you can get, assuming that you have a reasonably good internet connection. So Tele Triage. Now, nothing prevents a person who has got cough and cold. He need not have coronavirus, but he could be having another type of pneumonia. He could be having some other respiratory infection. He could be having a COPD, chronic obstructive pulmonary disease. People with diabetes, hypertension, immunocompromised, post-cancer, post-radiotherapy, and what have you are highly susceptible. An elderly person is highly susceptible. So we can, through the telephone, through a good algorithm which is available with you with a very high level of sensitivity and specificity, decide on which person should physically go to a hospital, and if he should go to a hospital, where exactly he should go to the hospital. Now, what is the exact meaning of the word triage? Triage can be described as a process of deciding which patient should be treated first based on a degree of sickness or severity of injury. As on 9th April, we have not yet reached this stage. We are all praying to God, and hopefully the measures taken are so fantastic that we will be able to flatten the curve. Personally, I somehow think we are not going to make use of the thousands of beds which have been set apart, the hundreds of ventilators which have been set apart. This is what we want. But in the very, very unlikely event that we do have this is what you need to practice. And you need to effectively decide on which patient needs a tele triage. Now, telephone triage is a process by which a trained clinician can identify a patient's problem, estimate the level of urgency, and render relevant advice to the patient over the phone. Today, this extends to the use of various connectivity options, including video, multimedia, remote tests, and software application. Chatbots have already been used by at least 40 to 50 hospitals in this country. Now, of course, this form was made about 2 weeks ago. Perhaps the form changes now. So every few days, the government is releasing a new method of doing a self-triage. Now, the ASHA, or the basic health worker, can evaluate the patient remotely using an approved flow chart or algorithm in the local language using the existing tablet. All of you know that 650 million Indians live in so-called rural India, where you certainly don't have secondary and tertiary hospitals. 95 of India's ID specialists, infective disease specialists, live in the state capitals and the metros. However, India is a paradox. We already have breached the 1 billion mark so far as mobile phones are concerned. 40% of them are already smartphones. So this ASHA from the remote end using an algorithm can effectively communicate, not with a doctor, can communicate with a trained paramedic who will help the ASHA do the initial filtration and the screening. The trained paramedic in a tier 2, tier 3 city or even a metro can, if necessary, escalate the case to an MBBS or even MD general medicine. And if it's a particularly difficult problem, the MD general medicine can escalate it to somebody with much more experience. All this can be done remotely. Telemedicine is a safety valve for a strained healthcare system. Virtual visits are the best way to decide who needs to be tested for COVID. It's impossible. Even if the government makes 100,000 tests available per day, never ever forget that every sixth human on this planet is living in India. With 1,350 million people, people can argue, but it's just not possible to do tests for asymptomatic. Forget asymptomatic, even symptomatic people, it's never ever going to be possible. Therefore, we need to filter, we need to do a triage remotely. So this is one of the ways in which COVID-19 pandemic can be controlled. Automated screening algorithms with local epidemiologic information. The brilliance of artificial intelligence is that we can customize these algorithms. The Nizamuddin Delhi, if somebody is coming from Nizamuddin Delhi, he'll be given more weightage than somebody who is in Lakshadweep or the Andaman and Nicobar Islands. If I am 70 years old and I have diabetes, hypertension, a cancer, I'm already being treated with chemotherapy, obviously the weightage will be more, and so on and so forth. All this is very simple, and this can be deployed at the remote test end. Most countries have a shortage of healthcare providers, and if they themselves need to be quarantined, it would lead to a disastrous situation. Not necessarily, not if there is telehealth. I am a doctor, I have been quarantined, I'm not allowed to go to the hospital, but my mental faculties are absolutely normal. I have a good internet connection at home. I know all about this. So I can tele-evaluate 1,000 people, if not 1,000, at least 200, 300 people. So every healthcare provider who is quarantined today, I don't know whether this is actually being done. This morning's TV, I read that in Wockhart's Hospital, 86 people have been quarantined from Wockhart's Hospital. These 86 people, each one of them could remotely evaluate at least 200 to 300 people. Very simple evaluation. So please remember, telemedicine is very, very useful, particularly in a pandemic situation like this. Health education, with a click of a button, it is possible through not only through multi-point video conferencing, through various, today we have so many platforms, various YouTube channels. I'm told with certain YouTube channels, you can even reach across to 10,000 people at the same time. With multiple methods, you can show videos, animations, clippings to millions of people, not just a cough, which you are now given over the telephone. So use of technology for all these purposes. Now, the telemedicine should be a national strategy. Of course, telemedicine has been repeatedly mentioned. And again, it's a great compliment to the government that within 10 days of the MCI notifying this, the Department of Ayush has also notified. Telemedicine guidelines have been given by the Department of Ayush. Ayurveda, Unani, Siddha, homeopathy is not covered, but these three are covered, and similar guidelines have already gone. So you can see here, telehealth alone will be effective, and this will help preserve the critical healthcare provider. All stakeholders in the system, whether private hospital, laboratories, or what have you, must need to embrace telemedicine. Today, as I showed you in one of the earlier slides, fever, cough, shortness of breath, every one of them can be evaluated remotely. I can look at your oxygen saturation. I can even predict with an uncanny precision what is your pulmonary reserve. We in Apollo Hospitals, Chennai, when necessary for COPD at a height of 14,000 feet, we have been doing various tests, pulmonary function test, spirometry. Today, it's not too expensive. Telespirometry can be done. I can find, I know every single clinical detail which is required in a suspected case of coronavirus can be done remotely. Digital stethoscopes not only transmit lung and heart sounds. This is simple. It's an audio file, 40 kb, 100 kb. The transmitted audio file can even have a description of the sounds. And just like you have a semi-automated ECG, the heart sounds and the lung sounds also will come with a semi-automated description. Blood pressure, pulse rate, respiratory rate, all this can all be monitored remotely. It's just a question of deploying technology. It's very important that we do not trust our memory. You have algorithms, charts like this. So simple to have these charts. Give it to everybody. Give it to an ASHA. Fever is common. It's rare in common cold. It is common in flu. But remember, it is not at all common in the common cold. Shortness of breath is much more common in COVID-19 than in a normal flu. Aches and pains and so on and so forth. So all this can be done. Again, there are so many algorithms like this, which gives you very clearly green, yellow, red. Of course, the contact history may, after a few weeks, become less important once transmission occurs from within the community. Just because I do not have a travel history or a history of a direct contact does not exclude me from COVID-19. Nevertheless, the weightage will be given depending on which part of the country you're coming from. So all this can be transferred digitally. So what is the way forward? I'm sure all of you remember a couple of years ago, the government said we are going to have multiple AIMS and multiple IITs. When I was a medical student, there were 4 IITs in the country. Today, I think there are about 25 or 30 IITs. There are at least 15 All India Institute of Medical Sciences. Ladies and gentlemen, the time is now opportune. When I passed out, there were 110 medical colleges in the country. Today, there are 465 medical colleges. Every 2 weeks, a new medical college is coming somewhere or the other. We have 700 district hospitals and at least 1,000 secondary to tertiary hospitals situated in the metro, state capitals, tier 2 and tier 3 cities. It is, if you can build a hospital, if you can build a medical college once a month or twice a month, I see no reason why you cannot have 100 or even 500 telemedicine units every day. It's all a question of the mind. The situation warrants it. And I do hope we will exploit, capitalize this situation. And I look forward in my lifetime to reach the day where telemedicine is no longer considered a subspecialty. We don't talk of the Stethoscope Society of India. The stethoscope, of course, now the stethoscope is dead. Today we use pocket-shaped echocardiograms. But whatever it is, telemedicine should not be considered a subspecialty. You should not require mad people like us to propagate telemedicine. Telemedicine should be an integral part of the health core of the healthcare delivery system, whether you be a pediatric cardiac surgeon, whether you be a fetal surgeon, whether you be a public health specialist, an epidemiologist, what have you, there is a definite role for remote healthcare. I do hope that we understand this and we make use of this opportunity. Digital health, ladies and gentlemen, is bringing out a real revolution. It is shifting the point of care to where it should have been all this time. The patient's abode, not the hospital. The point of care should be shifted from a quaternary care hospital to the patient. Today, it is possible to have a hospital in your pocket, a doctor in your pocket, a laboratory in your pocket. Awareness must be raised among patients about the benefits of telehealth. Technology acceptance and a behavior modification strategy should be considered. Even in 2020, in the United States, 88% of companies with 500 or more employees offered telemedicine as part of their health benefits. However, only 9% of eligible employees used it. This is not surprising. For 5,000 years, ever since the first doctor-patient face-to-face relationship started, it has always been the doctor physically touching you. In a couple of years, or even much earlier than that, the haptic sensation of touch will come. And I'm sure by wearing cyber gloves and using my mouse, I will be able to remotely palpate a multinodular goiter and decide whether it is solid, cystic, or calcified. But till such time, the healing touch which the doctor gives has to be through your own personality, how you react with the patient.